Yeah. Yes, and good morning, everyone, and thank you for attending our Phase 1 clinical trial short course lecture series. My name is Junxiao Hu, and I'm the Cancer Center biostatistician. And today I'm going to give you, this is the fourth lecture of our short course series. And today's topic is the Bayesian continuous reassessment method in Phase 1 clinical trial. Right, so first I will have an overview of the content of today's lecture. I'll start with an introduction of the Phase 1 trial design and to recap some of the basic concept and the basic terms in Phase 1 trial design. And then I'll start with the BCRM introduction, basic ideas of the BCRM method. And this is a model-based method. So we need to have the dose response model to use this method. So in the next section, I will introduce some of the most commonly used dose response models to model the dose responsive curve. And then after that, I'm going to go through how to implement the BCRM and then compare the operating characteristics to a 3+3 design and the summarization. Now I'll start with a brief introduction of the Phase 1 trial design. So the primary objective of Phase 1 trial design is to determine the recommended Phase 2 dose or the MTD. A lot of times the MTD is RP2D, but sometimes the RP2D could be different from the MTD. The basic assumption, this is true for all Phase 1 trial design if it involves dose escalation and de-escalation procedure. So the basic assumption is the higher dose means greater clinical efficacy. So that's why we want to do the Phase 1 trial design. We want to do the escalation stage to find, the best tolerated dose level. Okay. So before we can do this, we need to first define the dose limiting toxicity, which is DLT, right? And also we want to decide what is the targeted toxicity level, the TTL, so that we want to find the maximum tolerated dose level, which will give us the targeted toxicity level. So this is the basic idea of the Phase 1 trial design. And this is how we quantify our MTD and then, get the RP2D. Oh, and please feel free to stop me anytime if you have any question. And so here is what we assume about a good drug, right? A good treatment will always have the efficacy curve on top of toxicity curve, so that we will always have lower toxicity rate than the efficacy rate. So that will be the definition of an unsuccessful drug. And those curves can be used to model those efficacy curve or those toxicity curve. And in the Phase 1 trial, we will be focused on the dose toxicity curve. Okay. And in the Phase 1 trial design, we are seeking a method to provide us some type of optimality in consideration of safety, efficiency, and ethical conduct. For safety, it's easier to understand, right? We don't want to overdose patient. We don't want to assign the patient into a dose level which is too toxic. For efficiency, there are two concepts involved in the efficiency. First, in Phase 1 trial, we don't want to enroll too many patients just to try to find the MTD. We want to be able to decide or estimate the MTD use as less as few patients as possible. And also during the phase 1 trial, we want to assign most of our patients at the optimal dose level. So this is the efficiency. And for ethical conduct, basically is the combination of safety and efficiency. We want to treat our patient in phase 1 trial with the best possible treatment, okay? Which is the best dose levels. All right. So the best way, so we want to design our phase 1 trial to find the best way to get information about MTD and RP2D, and we want to treat each patient with the best treatment. And of course, it needs to be supported by the current evidence. What's the good thing about the BCRM is that the best treatment can be, the decision of the best treatment or the best dose level can be made by from all the previous observed evidence. So basically, we can use the information from all previous observed response, no matter what dose level it is. Okay. So here is the basic idea of the BCRM. So first, the BCRM, the most important characteristic of the BCRM is that the dose response level, the dose response relationship is modeled. All right. So we have a model, a dose response curve, functional to model the response, dose response relationship. And then the dose response relationship is estimated after each patient outcome is observed. So that's why it's continuous. So if in the ideal case, if allowed, then we can estimate, we can make our dose escalation, de-escalation decision after each patient, okay? And then the next patient is given the dose that is current estimate of the MTD, right? I want to say one more thing about the continuous part. So in practice, a lot of time, although in ideal case, we want to be able to estimate the next dose level for the next patient after each patient. But for logistic reason, in practice, we still use a cohort of 3 because of the convenience. So one particular reason is that, so after each patient is enrolled and treated at the current dose level, usually a time window will be assigned to allow us to observe the toxicity of that patient. Say, for example, 2 weeks toxicity time window is assigned. So if we really do the, we really try to estimate the dose level for next patient after each patient, then we need to wait about 2 weeks, right? After each patient is enrolled. In that case, it will lengthen the trial. And if a patient is here and every patient, it need to wait for 2 weeks until we can assign them to the next dose level. So logistically, this is not ideal. So although BCRM gave us the flexibility to really continuously monitor the trial and continuous estimate the MTD, in practice, a lot of time we can still use the cohort size of 3. But as I said, the BCRM gave us the flexibility to basically use any kind of cohort size instead of just cohort size of 3. We can use cohort size of 2, 3, or 4, depends on the practical situation. Okay. And so So for us to be able to use the BCRM, we need to first decide what is our target toxicity level. For example, in 3+3 design, the target toxicity level is 0.33. And the BCRM give us the flexibility to choose any of the possible target toxicity level. And then we will find the corresponding dose level according to our target toxicity level. So as I said before, the BCRM is a model-based method. So it used certain functional to model the dose responsive curve. And the most commonly used models are one parameter models. And here are some of the examples. For example, the hyperbolic tangent model. Here, the risk or the probability of toxicity is modeled as a tangent function of the dose level. The parameter is alpha here. And so we can see in this functional, the alpha is basically a power of the tangent function of dose level. And there's one parameter logistic model, and you can see the form is similar to the most commonly see logistic model, but the only difference is that the C here usually is the intercept of the logistic model, but the C is a fixed number. In the original BCRM paper, they recommend to set C to be 3. And the only parameter to be estimated or to be varied in this model is still alpha. And also the power model is pretty simple form. It's just power alpha to the dose levels. Okay. Those one parameter models gives great flexibility already, for various dose responsive curves. But if we think we want more flexibility, we want to be able to even more diverse dose responsive curves, we can use the two parameter model. The commonly used model is logistic model. Here we can see it's just logit of beta 1 and beta 2. And the only difference from this logistic model to the commonly used logistic model is the intercept now is taken to the log beta 1. Right? So to choose between the different dose response models, we want the model to perform well near the MTD so that we have an accurate estimate of the MTD. And we would want the model to be able to, we want to use the model to target the doses that have the required toxicity level. And, in the question for what model to choose, I will cite George Box. All models around, but some are useful. So a lot of times, it doesn't matter what models you're choosing, but it just matters if the model is flexible enough to approximate the true dose responsive curve. All right. So for each of the model, we're going to assume that for all theta, just a reminder, the theta is the target toxicity level. And the X star is the MTD. And then there exists an parameter number alpha such that it can map the MTD to the target toxicity level. Okay. Then our objective is to find this number A0 or alpha 0 so that we can find the MTD X star. So here's the BCRM basic idea. So the y-axis is the probability of DLT, okay? And the x-axis is the dose levels. And here theta is targeted is our targeted toxicity level, and X star is the actual MTD, right? So in this figure, we can see that there's a point corresponding to our TTL and MTD. Our model should be flexible enough, to go past this TTL and MTD corresponding point. And then we want to estimate alpha to find this curve. And then based on this curve, we're going to report or find our MTD X star. So this is basically how the BCRM works. And of course, even with one parameter model, we have enough flexibility to find, to find the curve, the dose response curve, to go past this MTD TTL corresponding point. So here's an example of the dose responsive model family, the hyperbolic tangent family. You can see it can model all different kinds of dose response relationship. And basically there's infinite number of dose response curve it can model, because alpha is a continuous variable from 0 to infinity. So you can see even with one parameter model, it provides you great flexibility already. And not to mention, we still have the 2-parameter logistic model. So this guarantees that the BCRM can be used in phase 1 design to find the MTD with the targeted toxicity level. Okay. Oh, and in this figure, there's one thing need to be noticed, that here we can see this dose level is not commonly see those levels in practice, like 5 milligram, 10 milligram, 50 milligram, because this is standardized dose. So the dose level in BCRM, the dose level is usually standardized, for computation reason and for modeling reason, so that our dose response curve is centered and there's no particular dose level have higher influence than the other dose levels. And here's how we can standardize the doses. The reason we're going to standardize the doses is to map the dose levels and corresponding priori gas toxicities to the chosen model. So this standardization is based on the prior gas, on the toxicity levels, on the set of study doses, the dose response model, and the initial gas of the parameters. So here are the examples for different standardized functional used in the BCRM method. In most software, the standardization can be done automatically. But if you're going to write your own program to do the BCRM, here's how you do the standardization. Okay. Are there any questions so far? Okay, good. So now I'm gonna start talking about how do we implement BCRM to find the MTD. So suppose the JACE patient has enrolled. Now we want to decide which dose level should we give to the JACE patient. So we're gonna make our decision based on all the previous patient's response. So we can use BCRM to do that, to recommend dose for the JACE patient, use all the previous observed patient's response. Okay. How do we do that? It's based on the likelihood function for the observations for each of the patient, and based on Bayes theorem. Based on Bayes theorem, we can find the posterior distribution of the parameter, say alpha. if we use one parameter models. Okay. And after we find the alpha, we have a specific functional to model the dose response curve, right? So if we know the alpha and we have the functional of dose response model, then we can estimate the toxicity level for each of the dose level I. And there are the two ways to estimate the toxicity level for dose level I. One is to use the plug-in estimator. Basically, we just plug in the posterior mean of alpha into our toxicity curve model, and then we can have the toxicity level of dose level I. Or we can be more fancier. We can use the Bayesian theorem to have the posterior distribution, use the MCMC method, of course, to have the posterior distribution of the toxicity level of dose level I, and we can estimate the toxicity level use its posterior mean itself. But computationally, it's easier to do the plug-in estimator, right? Because we only have to do one numerical integration to get the posterior mean of alpha. But if we're gonna do posterior mean of the toxicity level for each of the dose levels, then we need to do, like 3 or 4 or 5 numerical integrations. That's computationally more expensive. So in many software, the default setting is to use plug-in estimator. Okay. Right. So after we have estimated the alpha, now we have a certain curve like this. So this is our estimated dose response or dose toxicity curve. All right. And now we'll be able to estimate the toxicity levels at each of those levels, X1, X2, X3, and X4. And of course, we can find which dose level have the targeted toxicity level. And then we can recommend that dose level to the next patient. And or if in practice, a lot of time, the toxicity level is fixed and we cannot recommend in between those levels, then we could choose to recommend the dose levels closest to the target toxicity level. For example, here, we can recommend a dose level X3 or X2. Depends on how conservative your algorithm, you want your algorithm to be. Okay. And the other important feature of the BCRM is that we can do escalation with overdose control. So in previous slides, we recommend the MTD use the posterior mean, right? So, but if we want to be more conservative, we can use the lower quantile of the MTD. Usually, we can choose a quantile less than 0.5. Quantile of 0.25 is most commonly used. That means that we recommend the MTD with more restrictive criteria. Then this escalation strategy is more conservative than using the point estimate, for example, the posterior mean. So this is called the escalation with overdose control, is commonly used in the BCRM setting, and a lot of time is recommended by the FDA. Because one criticize of BCRM is too aggressive. Okay, if you have extra concerns about safety, you can use this escalation with overdose control method. Okay, and here is an example of how do we implement the BCRM with the one parameter power model. So to set up our BCRM algorithm, first we need to have our targeted toxicity level, right? And we have the flexibility to set it to be 0.3 or 0.25. Just remember in 3+3, the targeted toxicity level is fixed to be 0.33. And in BCRM, and we need to have a fixed number of patients to be treated in this phase. Here we can set it to be like 42 because we have 7 levels of dose we want to test in this phase 1 trial. And we will set the cohorts of 3 patients. So each time we will make our decision, each time we will enroll 3 patients and make our decision for escalation or de-escalation after we observe the toxicity, among those patients. And our prior guess of toxicity rate is 0.05, 0.1, 0.2, 0.3, 0.35, 0.4, 0.45 for those 7 dose levels, right? So basically, the dose level is 25 will be our MTD, okay? And we will use gamma 1,1 as prior distribution of the parameter. This is the prior distribution is basically a requirement for the Bayesian method. And the standardized doses are calculated using the plug-in mean estimate. And escalation decision will also be based on the plug-in estimate for consistency. And we can also add the constraint so that no dose skipping is allowed. It's most commonly setting in the phase 1 trial design. Because remember, in the BCRM, when we make the decision to recommend the MTD, for example, after we observe the patients assigned to dose level 5 and 10, the BCRM might recommend dose level 25 for your next cohorts to skip the 15 dose level. And a lot of time, if in cancer research, those treatments are really toxic, so you don't want that to happen. So we can add this constraint to say that no dose skipping is allowed. And we start at the dose level 5 milligram, which is the lowest dose level. Okay. And in the BCRM, you can start at any dose level. You can start at 5, 10, 15, or 25 if you believe 25 is your targeted, is your MTD. Okay, so one advantage of BCRM is it has great flexibility and it can be adjusted with different settings. Okay, and now here is an example trial of where those data is simulated, how this trial gonna go. So the first 3 cohorts, it started at the first dose level, which is 5 milligram. And although the one toxicity is 1 DLT is observed, but still the recommended dose level for next 3 cohorts is still level 2. And for the next cohort, there's no DLT, and the next recommended dose level for the next cohort is dose level 3, and just keep going up until dose level 5. And because too many DLTs is observed, so it's go down to dose level 4 and then goes down to dose level 3. So this is just an example of a clinical trial using BCRM. Okay. So after all 42 patients is assigned to different dose levels, now we want to recommend our MTD or RP2D. You can see that the BCRM method recommended dose 25 as your MTD and RP2D. So they recommended this dose level correctly. Okay. And here is the number of patients treated at each of the dose level and number of DLT observed. So those are the typical outcomes you can see from the BCRM algorithm. Okay, and just remember, this is just randomly generated data set based on, and here's the, just illustrate how the BCRM algorithm performed in the actual phase 1 trial. Okay. Any questions so far? Okay, great. Yep. Now we want to compare the operating characteristics to the traditional 3+3 design. And for sample size, of course, 3+3 designs sample size is varied. So it goes all the way from 0 to around 42 sample size. But our CRM method will have a fixed number of patients. This is actually, to me, is an advantage because it's easier for you to plan your phase 1 trial. There's no variability on the number of patients you're going to spend in this phase 1 trial. It's easier for budget and easier for your trial planning. And we can see that using CRM, you can assign most of your patient at your targeted dose level at your MTD, so that less patient is treated at the suboptimal dose levels. This is clearly an advantage of CRM compared to 3+3. And also, the CRM can recommend the right dose more frequently in simulation. You can see the 3+3 design most time recommend 15 milligram, which is the suboptimal dose level. Just remember the targeted, the MTD should be 25. Okay, so the CRM outperformed the traditional 3+3 design in recommendation of the correct dose level as the MTD. Okay, and the last figure on the right bottom, this one, is the percentage of subjects with the DLTs within a trial. At first, you might think 3+3 design is safer than CRM. Right? You can see most of the simulated trials has a percentage of DLT of around 18%. And for CRM, most percentage of the simulated trials has the percentage of DLT, at the 27 or 28%. Okay, but just remember our targeted toxicity level is 30%. Right? So basically, using 3+3, we can see that most patients are treated under suboptimal dose levels. So that's why the patient have a smaller percentage of DLTs during the phase 1 trial. But using CRM, most patients assigned to the most efficacious dose level, while still maintain the percentage of DLTs at our targeted toxicity levels. So compared to 3+3, of course, the BCRM outperformed the 3+3 method. Okay, so that's why we recommend new phase 1 trial designs instead of 3+3 if we're gonna do the phase 1 trial. Okay. So in summary, the BCRM method is pretty good and valid trial designs for phase 1 dose escalation trial. So first, the target toxicity level can be explicitly defined. It does not have to be 0.33 as in the 3+3 design. And it can use all available information from all patients for dose escalation decisions and for RP2D. So that our RP2D estimation is more accurate and it's more efficient. And because we have assumed those response models, so it allows more rapid dose escalation. You can see from trial example, it just goes from the lowest dose to our targeted dose fairly quickly. And more patients will be treated at optimal dose compared to 3+3. And another important characteristic is that BCRM will require real-time biostatistical support for dose escalation decisions. So basically, for BCRM, there's no table as 3+3 or the bone design or the MTPI. Each time if you're going to make dose escalation or de-escalation decision, we need to run through the BCRM algorithm, and then we can report you the recommended dose level for the next patient's cohort. This will be a good thing or a bad thing. I personally think it's a good thing because it won't take much long for us, biostatistician, to provide you the dose escalation decisions after we have this algorithm set up. And also we can help check each time of your safety data and kind of monitor the trial continuously. And there is dose response model assumptions. This is the difference between the BCRM and the previous mentioned like bone design or MTPI designs. Some people have concerns about the dose response model assumptions, but the original paper and the papers afterwards evaluating the BCRM method shows that those dose response model is robust. So even with misspecification, it can still perform well in terms of finding the MTD and finding the correct RP2D. And also the operating characteristics is still supreme compared to the 3+3 design. Right? So this is today's lecture. We have introduced the BCRM method and have a brief description about how it works and how to implement the BCRM. So please let me know if you have any questions.
Thanks, Jim.
And thank you for organizing this series of lecture.
Yeah, and just a reminder, everybody on here, next week will be our last one, and Dr. Junxiao will be presenting on methods dealing with delayed toxicity. Thank you.